And to give you a little bit more background for me, I'm Amber Jones. I actually am a resident of Lakewood, so I'm very excited to be able to share with you guys the work that we've been doing in Old Brooklyn and eventually how it will impact me as a resident here. But my background is in public health. I got my degree from Case Western, and so I've been working with Old Brooklyn for the last few, thank you, the last few years on our health work.
Jeff Rusby, I'm not a resident of Lakewood, but I'm close. I live in the city of Cleveland, across the West 117th Street border in the Edgewater neighborhood. So I'm in Lakewood enough. My doctor's office currently is in Lakewood, so although they're moving to Rocky River, but great town, love it. So thank you Trish for inviting us. Do you want me to kind of dive into how we got to this point, or? Okay. So Old Brooklyn Community Development Corporation, like many CDCs in the city of Cleveland, has been around for nearly 50 years and has historically focused on what we call the bricks and the sticks. How many houses can we build and how many storefronts can we renovate, which has great value. The city of Lakewood has done a very good job of that. Some communities in Cleveland have done a very good job of that. I became the executive director there in 2014 after some time at Ohio City Incorporated. And it was when we were deep into a comprehensive strategic planning process in the fall of 2015 when the consultant who was doing that work told me that we are going to be investing in community health. And I'll be honest with you, as someone who worked at Ohio City Incorporated, think of what that neighborhood looks like. And prior to that, I worked at University Circle Incorporated, think of what they do over at UCI. I wanted to throw him out of my office. And I said, what are you talking about? I said, you're going to give me a plan on how many houses and condos we can build and how many new breweries we can open up, because that's what we do. And he said, so you for 40 years you've been doing that. He said, have you actually made your community healthier? He said, for 40 years you've been doing that. Have you measured success regarding the actual outcomes of the lives of the people who live in your community? Which humbled me a little bit, because I couldn't even answer the question, and then I suspected what type of answer I'd get, knowing what trajectory the city of Cleveland's been on the last 40 years. And I had never even heard of the phrase social determinants of health. It was completely a foreign subject to me. But like most born-agains, I am now the loudest apostle. And our consultant said at the time, he said, look, you're already in this space. As a comprehensive community development corporation, do you care about parks? Yes. Do you care about transportation equity and kind of mobility and access inclusion? Yes. He said, do you care about education? Yes. He said, do you care about safe, quality, affordable housing for all? Yes. He said, you're already in the social determinants of health. He said, you just don't know it, you've never measured it, and you've never focused that way. And so my board and I took a deep leap of faith and adopted a strategic plan that placed community health at the very center of our work, because we believed at the time that as we got into the research, the future of community development and public health must come together. So we adopted our strategic plan in early 2016 that said we are going to be a community health focused organization. And then I woke up the next day and I said, I have no idea what that means. And so let me kind of bring you up to speed of where we are. We spent a year defining what that was. We spent a year talking to those same folks in Boston and those same folks in San Francisco and those same folks in New Orleans saying, what is community health? How do you define it? What does it look like in your neighborhood? And through that process, through talking to the folks here in Cleveland, we decided to ask for some foundations for support to hire a community health fellow. Cleveland Foundation Enterprise Community Partners came in, supported a 2-year fellowship to build out our community health model. In that process of asking people what is community health, we realized that community health is rooted in 2 things. It's rooted in your residents and rooted in partnerships. And in order to accomplish that, we're going to need to open our doors to organizations that normally don't sit at our table. And that is in every way. That means opening our doors to clinical partners who have no idea what community development is. That also means opening our doors and actually taking our conversation to residents who normally aren't at boardroom and conference room tables like this. And we had to do both of those things at the same time. We had to do both those things at the same time. So we brought on our community health fellow, Dr. Jennifer King, who has her PhD in public health in May of 2017, with the explicit task to do two things: to launch a community health steering committee and to conduct a community health needs assessment. As real quick background on the second piece, if you don't know, community health needs assessment have been around for a long time, but they've become codified in the IRS tax code. If you want to maintain your nonprofit healthcare system status per the Affordable Care Act, you need to conduct a community health needs assessment. Basically, for your population, what are the challenges and how are you going to address that? So they're very commonly done by the hospitals. You can go on clinics and read theirs. I'm sure it's wonderful. You can go on, let's pick one, Akron Children's. You can go on theirs. You can go on UH. Metro Health is not required to do one, but they do one out of the goodness of their heart. The county governments do them. They're pretty standard. We conducted what we believe to be, and we proudly say is the only neighborhood-based community health needs assessment in the country. Because again, these things are normally done by county governments, these things are normally done in healthcare systems that look and say, hey, across the 17 county area of Northeast Ohio, what are our problems? We know what our problems are in the 17 county area. But that doesn't tell you how to actually help the people on the street next to you. And so we wanted to kind of change that dynamic and take that same rigor down to a neighborhood community level. Why did we do that? Because, and a lot of you talked about it here, is because what we realized is if your zip code matters more than your genetic code, which is pretty widely accepted at this point, there is no entity that cares about your zip code more than your community development corporation. The city of Cleveland can't do it because they serve 11 zip codes. County government certainly can't do it. We are the only entity that can care about that zip code in a comprehensive way. And so if your health is maybe 10 to 20% what happens inside the halls of the hospital, maybe 25% about the choices you make and the lifestyle you live, and everything else is about the physical environment around you, your access to jobs, your access to care, your access to mobility, your access to education, your access to green space, your access to food. If that matters 65% of your health outcomes, why are we not spending more time thinking about it and driving investments in that way? And so that was the root of it. So Jennifer created a pretty amazing steering committee that, again, brought together partners who normally don't talk. That included a whole host of partners from our clinical partners, mainly Metro Health, but we do engage a little bit with the clinic and with UH. That was researchers at Metro Health who are doing population health research all the time, but have no idea what's actually happening out in the population. That include family practitioners who are talking with community members all the time, but have no idea where to help, or they're talking with their patients who are out in the community all the time, but have no idea what's happening out in the community and how to help their patients. That included talking with partners like Neighborhood Family Practice, partners like other community service organizations. In Lakewood, it would be Trish's group, but in Old Brooklyn, the Senior Center is such a logical partner in something like this, but we never collaborated in this way to improve health outcomes for that population. It includes our academic partners, Baldwin Wallace University, Case Western Reserve University primarily, and their research teams, their prevention research centers. BW doesn't have a PRC, but it's their public health department, who are looking at these matters as well. It also had to include residents from day one. Because ultimately, if we don't root this work in their voice and their ownership, then we're just a bunch of fancy people in suits coming up with programs for our own benefit, but not actually driving change. So Jennifer created a very robust steering committee. She spent 6 to 8 months focus grouping and having small conversations with residents about what mattered to them. And it wasn't, hey, come to City Hall at 6 p.m. on Tuesday and tell us what matters. It was going to the festivals, it was going to the church parties, it was going to the T-ball nights, and just sitting down and talking with parents and say, what barriers are in front of you that prevent you from living a healthy life? What are the things that would help you and your family succeed more? So that we could start to understand the domains of health that really mattered to our population. We then partnered with, again, that steering committee, Federal Reserve Bank, Cleveland Neighborhood Progress, Cleveland Foundation, Baldwin Wallace, CWRU, our residents, to create the Community Health Needs Assessment. Our CHNA was a 37 question tool. We did get IRB approval for IRB as Institutional Review Board. And the reason why we do that is because a lot of organizations, I'm sure you all included, do a lot of community surveys. But the difference between a community health needs assessment and a community survey is that one is statistically significant and the one isn't. And so in order to adhere to statistically significant processes as well as ethically appropriate medical research, we went through Institutional Review Board at Baldwin Wallace. That's a pain in the behind, an absolute pain in the behind. But it is the right thing to do because part of the question, part of your process is when I'm asking community members difficult questions about their substance use, difficult questions about their mental health, difficult questions about their food insecurity or housing insecurity, I need to know that I'm doing so in a responsible way to not induce additional trauma from what they already may be experiencing. So in addition, by doing it the overly rigorous way, we were able to ensure that our process was as inclusive and statistically significant possible. We geocoded responses. We all know if you all put out a survey, I'm guessing you know what parts of Lakewood are going to respond immediately and tell you what matters to them. They're the same folks that come to every community meeting. We wanted to avoid, I know who those folks are in Old Brooklyn. We wanted to avoid that. And so once we started to hit certain numbers within certain demographics and certain geographies, we stopped collecting responses if you kind of started down that road. And that also allowed us to oversample in other parts of the neighborhood, oversample with other populations to ensure that we had as equitable a response as possible. We still weren't perfect, and I'll acknowledge that. We did really, really well. We still messed up in some ways because it's hard work to do. Ultimately, the assessment was about a 2-month process, and then the data analysis was probably another 2-month process. It was a laborious process. It was a costly process from a staffing resource perspective, but it did give us what I consider to be the best neighborhood-based community health tool in the country. So we published the Health and Action Report, all of you have in front of you, last September. It identified 6 domains that really plague our community. 4 of them, I think, are really Old Brooklyn focused, and 2 of them you could say that is common for good chunks of Cuyahoga County. In no particular order, let me run through them. The first one that I think is really interesting, and I don't know how they are in the book, so please excuse me, is this matter of green space and equity. Old Brooklyn often boasts about how we have more acreage of green space than any other neighborhood in the city of Cleveland. That's correct, because the zoo's in Old Brooklyn, and so is Brookside Reservation. So there's like 2,000 acres of green space in the neighborhood that counts. So it's like, hey, technically, yes, we have more. But we found out through this assessment, totally shocked us, 60% of our residents never access an Old Brooklyn park. That was a bit of a surprise. As we broke down the data more, we realized that majority of our residents, especially in the center chunk, don't have any parks near them. All of our parks kind of ring the neighborhood closest to the wealthiest subsections of the neighborhood as well. And so that was one kind of eye-opener to us. A second, which is common to many communities in Cleveland, we are a food desert. We also have major food insecurity. That's a common challenge that many neighborhoods in Cleveland face that I know doesn't challenge Lakewood perhaps as much. A third that is, I think, special for Old Brooklyn is this matter of neighborhood resources. We were a neighborhood that historically has been viewed as very stable, very middle class. We've gone through massive shifts in the neighborhood in the last 30 years. We've had a 300% increase in our poverty level since 2000. We were a neighborhood that didn't know poverty. It was like 7% in 2000. And so accordingly, our community members who have need don't have services to turn to. because the social service industrial complex has not yet caught up to the fact that our neighborhood has need. And in addition, I believe it was around 50% of our residents said that if they were having what we would call kind of a mental health day, there was more appropriate language as guided by our academic and statistical partners. I don't know what that language is. I'm sorry. I'm just the dolt who signs checks around the office. But for 50% of our residents who were having challenges with mental health said they wouldn't know where to turn if they needed help. That's a huge issue. And then the fourth one, and then our housing challenges in Old Brooklyn are largely around aging in place and predatory landlords. So those were our housing challenges. And then the fifth and the sixth ones, substance use. 10% of our residents admitted to prescription drug abuse, misuse. Sorry, I always get corrected by my public health colleagues. Misuse, not abuse, which that's a lot. 10%. 10%. And of those who admitted misuse, only 3% said they were on a plan or had a plan to correct that behavior. So that's pretty terrible. And then in Old Brooklyn, that's largely opioids. And then the chronic disease challenges that we have, they're the same as everywhere in Cuyahoga County, arthritis, obesity, and hypertension. So those were our 6 things. So it's great. So we had this really robust steering committee. We brought people to the table who were able to challenge our work and say, hold up, you need to look at this differently because I have my domain of expertise and I'm bringing it to the table. We brought residents to the table so their voice was a part of the process. We assessed the neighborhood, we published that document, and then we said, okay, so now what? We developed a framework for interventions, and I'm going to stop talking and hand it off in a second. I love this work. It shouldn't put the apostle first. I get crazy. Our framework of interventions is kind of layered together, but we look at every intervention as short-term, midterm, and long-term. Short-term is service delivery, food insecurity, food bank type. Like let's use food as an example. Food insecurity, food bank. Midterm is community conditions. That would be building a grocery store, if we're staying in the food access bit. And long-term is always policy and systems change. So that could be matters as it relates to prescription, food as a prescription, or SNAP and WIC policies and bits like that. So that we look at every intervention we do on how are we addressing short, mid, and long term in each intervention, and then we undergird each intervention kind of with what we believe to be the foundational challenges that touch all 6, and that is structural and institutional racism, and that's economic opportunity. Because if we don't address those 2, for those of you, our colleague at the Cleveland Clinic, the keynote yesterday at the Population Health Symposium said, look, if you aren't talking about economics, you can't address the social determinants of health. So and we know that to be true as well. So that is the background, that's the context, and I'll hand it to Amber to talk about what we're actually doing.
Okay. So like Jeff said, it has been a long process, and when we got to the completion of the CHNA, we had this published book laying out kind of the groundwork of where we wanted to go. We had to figure out exactly what we were going to do moving forward. That's the big question. We have food access issues, we have green space equity, housing. So how do you prioritize that? Because it is a lot. There's a lot of things that go into that. And so looking at what we were already doing and then inspecting it to see what are the changes we can make in those 6 focus areas. So the first one that we looked at was food access. We have hosted a farmers market in Old Brooklyn for the last 4 years. 3 years. This was the 4th year, I think. However, our farmers market was located in an area of the neighborhood that was primarily better to do in a neighborhood park, which is fabulous. It's a beautiful park, but it's tucked away in the neighborhood. You do not have access to it off of a main road. You would have to know it was happening in order to actually go. And so that means social media, most likely, is the best, most easily approached way of getting the word out these days. So if you didn't see a poster in a shop or get a flyer at a meeting, then social media was the way you're going to see it. So that was one of the things. And along with the farmers market, it was hosted on a Tuesday night in conjunction with our movie nights, which was a great summer activity. You get a bunch of community members out, but what we noticed last year when this was happening was people would come for the farmers market, and then there was about an hour delay. And so the people who actually came to the farmers market didn't stay for the movie nights. So that led us to question, okay, well, what if it were on a different day? So Tuesday nights, 5 to 8 p.m., those are busy nights for working people. It's hard to get to. It was not on a major bus line. And so when we went through the planning process for this year, one of the things, we questioned all of these things that impact a person's ability to get healthy, fresh food. And with that, we decided to move it to Saturday mornings on our main street, where a bus line, the Metro Health line, passes through. A lot of these aspects that enable people to have healthy foods, healthy food access. One thing that I wanted to note that I don't remember Jeff saying is we don't have a full-service grocery store in Old Brooklyn. We have a couple Save-A-Lots. There is a Giant Eagle, but it's not technically in Old Brooklyn. It's in Brooklyn, and so on the edge of the neighborhood. So you have to travel. Most people on average traveled, and we learned this from doing our CHNA, 10 minutes to get to a grocery store. If you drive 10 minutes, you are not in your own neighborhood. And so that was one of the really important things. People were leaving Old Brooklyn to get food. And imagine if you didn't have a car. How are you going to get there? There's only one bus line. It goes up and down Pearl. So you can't get anywhere. And so that was really important to us, was to have something in the center of the neighborhood where people can actually get there. So on top of that, as part of our health initiative is to layer in different aspects of health. We know healthy food is not the only thing that impacts a person's health. It's the ability to have safe places to exercise, be outside, as well as where your health resources are. There's a lot of mistrust in the health system. So how can we bring in our health partners into our farmers market? And along with that, we had fresh produce, but does that mean people are actually going to buy it? Do they know what to do with it? And so we offered free cooking demonstrations paired with nutrition information. And so all of this, our whole farmers market had layers of healthy activities and information and things that are key to living a healthier life. So with this, I will list off all the things we did because it's a lot. We had free fitness activities every week. We did yoga, Zumba, and Tai Chi. We had the free cooking demonstrations. And with that, we had 3 different chefs who came in every other week or so to pair that with taking vegetables that you can buy at the market. They picked up the squash. They picked up the eggplant, because who knows what to do with an eggplant, really. They picked up all of these things that you can actually buy at the market, supplemented it with a little things from the grocery store, as you would need to, because you can't buy everything at a market, and actually made the food, showed people how to do all of these things. And I have to say, the cooking demonstrations were one of the best things about our market. People loved them. They would come every single week just for the cooking demonstrations.
Can I jump in, just because I like to also keep it pretty real? We were incredibly intentional about the chefs and the nutritionists that we selected, who were majority persons of color, because farmers markets are seen as white middle-class spaces, and so we wanted to very much lead that this was a space for all. And actually, I might argue that our cooking classes were probably the most inclusive, diverse part of our entire program.
Mm-hmm. And that diversity in our chefs extended to all of our partners who came in for the programming of the market. So we had musicians from all over Cleveland of different backgrounds. Our fitness instructors were primarily from Old Brooklyn. They were Old Brooklyn residents, so like how can we get them involved? And along with that, you know, our health resources, we had recovery resources on site. They're across the street from our new office. We had Metro Health on site to do some outreach. And then along with all of these things, on top of that, because if that wasn't enough, we also ran a neighborhood circulator all summer for people in the neighborhood. So what that means is we had 2 routes that ran through the neighborhood, an east and a west route, where people were incentivized to ride the transit line to the market and other locations in the neighborhood. So that was pharmacies. So we have a Walgreens and a CVS on our bus routes. We had the full-service grocery store, Giant Eagle, as one of the stops on our bus routes. We also had our CMHA property, as well as senior and disabled housing that are on the edges of the neighborhood. And when we do outreach in those locations, the number one thing we always hear is we can't get there. We have these programs, we have these great things going on in the neighborhood, we can't get there. So as part of our planning process that was our number one thing. How can we get the people to the market? And so with that, it took a lot of planning and our partners. I will say Senior Citizen Resources were our number one partners in our transit. They provided our buses, their buses to us for the summer, because they use them during the week and then they sit idle on the weekends. And so it was a natural fit. The bus drivers made these really great connections with the residents. And it was, you know, a lot of the same people coming every week. They would come up to us and be like, you know, if this weren't here, we wouldn't have been able to come. And I think that's a really important piece when you're thinking about the health of the community, is how are you addressing not just one factor, but many factors? Because, you know, a farmer's market could be just a farmer's market. But in reality, if you want to make changes in the community, it needs to be more than that. So that is one of our interventions that we've just wrapped up last week.
She missed like 5 additional things we did every Saturday too.
Oh, please go ahead.
Like a literacy
That's a lot.
program, arts and
Oh,
cultural
yeah.
program, a group bike ride, and a group run.
Yeah.
Did I miss anything else?
No, I think that's everything.
Yeah, every Saturday.
I'm ready. I was ready to be done because I was coordinating all of it. So it was an amazing summer, and many of the residents, and Jeff can speak to this from last week. Last week was our last farmers market of the season. We had so many residents coming up to us saying, "Thank you so much for doing this. It was one of the best things about our summer and about coming out to the neighborhood." And we're really hoping next year you're back. You do it bigger and better.
No, it's great. And just I want to tie the loop and quick handoff and then open up for dialogue. I think ultimately then you could say, okay, so that's great community work, yes. What differentiates our work is that it's rooted in resident voice. Residents told us this is what we're going to do. And we're driving everything through data outcomes. So I don't know if you want to share some of the quick highlight. And I think that's the difference of what we've traditionally done versus what we're doing now, and then happy to answer any questions.
Yeah, so along with this long process with the farmers market, having all of these health interventions, we wanted to make sure that when we did this, we did evaluations. If you don't evaluate the process and the whole experience, then you cannot know your outcomes. You cannot know if you were successful. And so part of our process was each week we had staff members do surveys with our residents, asking them different questions. One of them, do you live in Old Brooklyn? Like, that's really important for us. How far did you travel to get here? What activities are you participating in? And so it really depends on the community, what you want to know, what you want to learn. But for us, those types of questions are really important as we move forward, especially with health outcomes. So I just want to share, this was very quickly done this morning since the market wrapped up on Saturday. But 71% of the people who took the survey and were at the market were Old Brooklyn residents. So that means that we were actually reaching the people that we wanted to come to our farmers market. We were actually making a difference in the people who live closest to it. So in addition to that, 40% lived less than a mile away, which was amazing.
Yeah, especially because Amber's point earlier, the farmer's market used to be in one of our higher income census tracts. We moved it to our lowest income census tract, and residents there were served by it.
And along with that number, 42% lived 1 to 4 miles away. So over 80% were within, that radius. So that was a really close knit, and that's what we were looking for. That was the number one question we asked when we started planning for this summer, was who is this market for? We have to keep that in mind. Who are we doing this for? And so it was really great to see that data points. And then the last one I'll share with you was 31% actually took alternative modes of transportation to the market, which was really astounding because it's a very car-centric neighborhood. And so, that includes walking to the market. A lot of people walked who were close. Biking, so we had the bike ride, but it also, in conjunction with that, people wanted to come to the market via bike. And then the transit system, that the Diamond Line was part of that alternative modes of transportation. So that's a really great piece of data that we've been looking at. And so throughout the whole summer, we had 366 surveys completed, which is 20% of our estimated total attendance for the summer. So that was a really great thing to see, and to really get an in-depth look at the community voice, what people would like to see, how they would like to move forward, what they're hoping for next year. And part of this process, doing it every week, made it so that as we were going throughout the market season, we could make changes, we could make improvements. If people wanted to know one thing, like someone came up to us and they were like, we really don't know where to park. And so it's like, okay, that's something that's really important because, people do use their cars, they want to know where to go. So, we put up parking signs. But having this iterative practice, going through it and talking with people, learning what they're looking for, what they would like, is really important. And then also not just letting it sit in a box. Don't let all this data sit on the sidelines. This should be used. And we'll go through this, we'll have a debrief session and look at this data and be like, okay, these things were really great, now how can we improve it for next year? And without data to support it, then you won't know if you're actually making those improvements throughout the process.
Y'all can see why Amber does this work and why she leads this work in our office, because what you had right there hit it on the head for me. It is the resident voice that causes iterative change because we're listening throughout the time, and we know that what we're doing on day one, we're probably gonna mess up a lot, but we just keep learning and we change and we go all the time. Happy to answer questions, but we can kind of keep going, but I think we've talked a lot.
I have a couple questions.
Yeah.
So you're a neighborhood in the city of Cleveland. What was the involvement, if any, or what is the involvement with your organization of the city officials?
Yeah, so Director Gordon and a couple of our commissioners are part of our community health steering committee.
Okay.
The director usually does not attend, but her kind of senior staff do. And I would say it's supportive, but the City of Cleveland's Public Health Department is largely more of a regulatory body than a kind of a proactive preventative body.
Mm-hmm.
So, Merle's been a huge champion from day one, and they love it, but it's more of a, we're here to support.
And just also, what is your staff that is involved with this? How many people are we talking about?
Well, so because we're now a community health-facing organization, all of us are, but we have a full-time staff of 9, about $1 million operating budget, so we're a small shop. A little bit bigger than Lakewood Alive, but not much. We have a director of community health, Heather, our colleague, who really is the real boss. Amber is the lead for a lot of our community health interventions, and then a whole army of graduate student volunteers and researchers who do amazing work.
I'm not even going to bother, I'm just going to yell.
Yeah.
When you did this strategic plan, you said that your consultant came back and said you're going to have to focus on health. How did he or she come to that determination?
So the consultant's name is John Lynch. JGL Strategy is his company, and he's just one of those kind of consultants who I think ties different things together. It was an exhaustive strategic planning process. We probably talked to 1,000 people, residents, stakeholders, and otherwise. And I think, he was looking at, really, it was the confluence of two pieces largely. A need for community organizations to address more matters of quality of life because of the challenges that relate to kind of changing economy and the social safety net, if you will. That's on one side, and the other is the huge changes in funding streams for community organizations and for healthcare partners. And I think he saw the confluence of those two things as a way to come together.
So are you still doing the storefront renovations and building apartments and houses?
Yeah, we still are. And actually, one of our colleague Rosemary, who leads all of our bricks and sticks work, if you will, is probably one of the biggest people who will slam on the table about this work as well, because she will say her work is creating a healthier, when she takes a vacant building and renovates it and uses community information to inform of, one of our, directly to a storefront need, we have a great need for wellness in the neighborhood. There's not a gym, there's a rec center, but there's some challenges with the City of Cleveland's rec center. There are no of the kind of studio facilities that exist anywhere, and it's the number one thing we hear from residents. So her work of trying to find a building and trying to find an entrepreneur to fill that is a healthy community health outcome. And the housing piece, the connection between health and housing is inextricable. I mean, that data is overwhelming. So that's pretty clear, especially with Cleveland's work moving into some of the lead, is it abatement or remediation? Lead safe work. Yeah.
I have a question. Oh, sorry. Can you talk a little bit about how the healthcare providers were involved?
So, Metro Health is a very deep partner. They serve on our board. Their second largest facility is in Old Brooklyn. They are very invested in population health. And so we've used a kind of a catch-all approach. And so we have a whole host of folks from Metro Health who are involved. We have their director of community health. We also have their director of community and economic development, kind of the more the bricks and sticks side. We also have their lead population health researchers. We'll take anyone who's interested, really. And Metro Health, I'd say, has been a partner in terms of a thought leader, in terms of pushing us differently, in terms of challenging us on how we evaluate data and evaluate success, because they might look at something very differently. Or they might say, hey, look, we have a lot of alignment here because one of the space that we're moving into is housing, kind of this collaborative healthy housing work. And they're in that space as well, particularly as it relates to asthma and children's asthma challenges. How the housing conditions and asthma are interlinked. So we're now diving into them on how we create shared data sets, which is a multi-year scary process, but that's kind of where we're going with them. They're not a major partner in terms of financial resources. It's more brain power and collective will rather than them writing a big check, which I'll take, to be honest with you. I'd rather have them be present at the table than anything else.
Thank you.
Thank you so much for coming and being so open and all this great work. It's really wonderful. I'm just going nuts with questions, but just that last point, since it's so fresh, can you talk about the funding?
Yeah, so we were originally funded a couple of years through Cleveland Foundation and Enterprise Community Partners. We then received last year a very significant grant from the Ohio CDC Association, but it was in partnership with the CareSource Foundation. So the CareSource Foundation released a very large social determinants of health RFP, and we received the largest one in the state of Ohio. So that allowed us to continue our work till now. And at this point, I'll be honest with you, we are in a hunting game for the next round. I think we've identified who might be a lead partner to kind of take care of the leadership of the work. And then after that's programmatic. And so this is where collaboration is key in community health. Every grant we apply for says, who are all your partners? And we're fortunate that Metro Health is so close to us. The CDC to the north of us is so close. The Senior Center is so close to us. The City of Cleveland is a good partner. But there's no way we could be pursuing these opportunities with Kresge, with Robert Woods Johnson, with even Enterprise National, the Cigna one that we're working on. There's no way we could do that if we were going alone. And so
Can you tell, like, what kind of dollars are you talking about?
Oh, boy. So to effectively give us good capacity, I feel like I need 150 to 170 a year to really do it well. That supports really great staff who are doing it. That supports staff both who are executing, leading, and coordinating programs, but also staff who are setting vision, who are building relationships, and some program dollars. I don't think that's unrealistic. When you think about what we're spending in a community for health outcomes in the 10 or 15% at healthcare institutions, lovingly, we have a really, really financially viable sick care system in America, where we spend a lot of money on sick people. We aren't actually spending money on keeping people healthy, and so I think that's a fraction of a cost for us to invest.
That seems really low to me.
Yeah, me too.
I think we can do it.
Yeah.
I mean, I think any community that if you're committing that to upstream community health matters, oh boy, you're gonna move the needle quickly.
Yeah.
So for the discovery phase where you're doing the CHNA, how did that take 4 months or was it longer? And what was the budget like for that?
You or me?
So the actual process of the CHNA took probably about a year between the actual planning, coming up with what are the questions that are important for our community. And that was something that Jeff talked about earlier, is with our steering committee, going through it with them, going through it with our residents, making sure that people felt comfortable answering the questions that we had on the table, and narrowing it down to something that was reasonable. Like 37 questions, that's doable in 10 minutes. We could not have something that had 100 questions, because who would do it? And so that part of the process took a few months. Then there was the actual gathering of information, where we went out into the community and talked with people, sat down with people, sometimes read the questions to them, if need be, to make sure that their voices were heard as well, not just people who could take it on the internet. And so that took 2 months, and then the actual data analysis, going through all of it, organizing it, cleaning the data, going all of that, coming up with what were our focus areas. That took 2 to 3 months as well.
From a resource perspective, that was one PhD fellow, so you can think about what cost of that person for a year, and then the gracious help of a boatload of volunteers.
That's the advisory committee?
That was the advisory committee, as well as a lot of MPH students from BW and CWRU who would sit in the library for 4 to 6 hours at a time trying to talk to residents.
Were they trained how to use this instrument?
Yeah, and so that's also because we went through Institutional Review Board at BW, it involved a lot of training. And that's why it takes many months to do it, because you want to ensure that anyone who's doing this is following the appropriate protocols.
So on that note, what are the outcomes you're trying to impact with all these interventions? What are the outcomes?
I'll tell you the scary answer that gets my board shaking and makes them want to fire me. I want to improve life expectancy and the conditions of life during that life expectancy.
How do you? I think life expectancy is pretty easy to measure, but how do you measure
so chronic
the other
disease, food access. How many folks. I want to drive down the number of folks who are food insecure. I want to increase the folks who have a grocery store within 10 minutes. We want every resident to be able to walk to a park within 10 minutes. We want to drive down the housing insecurity and the instances of lead exposure within our neighborhood. We want to eliminate the housing burden within the neighborhood. We want to decrease chronic disease. Those are the things. I tell my board, we are measuring that. Those are 30-year measures. I get that. But if we don't measure off of that, then we're just back to the same old, hey, we had 10,000 people come to a festival. We're doing a great job. Okay.
Yeah, I mean, that's why I'm asking. So I'm an epidemiologist by training, so that's why I think these endpoints are really, critical. So when you're doing the surveys like this year, are you able to get some of that baseline data? And then when you're talking about doing shared data sets or merging data sets with Metro or the clinic, are you going to be leveraging like I mean, that's where you leverage the IRB
Yeah.
to maybe do, you
Yeah.
know, more.
Long-term, I would love it
merge
if we don't
studies.
own that CHNA process, candidly. I'd love one of our partners to say, we're going to give you a researcher for 6 months to get this done. That would be great. And because that way we can just kind of create a deeper alignment and shared data, which would be nice. But we do, I mean, the CHNA gave us our first baseline, so we now have that from 2018. So whether we go back in 2020 or 2021, we can every few years baseline against that point.
Okay.
And then iteratively is more of the kind of, how would you define, I mean, I think the data, we don't ask folks like in our assessment, like, how many asthma attacks did you have the last year? We do ask them, like, does this program make you feel more welcome? Does this program make you feel healthier? Which hopefully can be the pieces that lead to it.
And another part of like our process is building social cohesion in the neighborhood. And with that, you know, do you feel more welcome? That's a really important part of building a healthier community, is having those social connections. And so that's one piece as part of our farmers market that I didn't touch on, but is really important, is, you know, we have those people coming back every week. And how are we creating those connections that people can feel safer in their community? Because safety is a big thing, perceived safety in your neighborhood. Do you feel safe? Like, that is something that's really big. And if that's the type of question a CDC can ask, whereas we can't like always ask those really hard questions that a hospital can ask you. And so that's why partnership is really important. So, you know, when we have this data sharing with Metro Health, is we can not see who the people are in our neighborhood, but know like the rates of incidence for asthma or high blood pressure, like in working with them to then have programs available in our neighborhood that can have a positive impact on the health of the residents. Because that's not something that a hospital can do, is have those programs always in the neighborhood. That's something that we're able to do. And so I think that's a really important thing to make clear.
There's a specific part of that that I think deserves called out. They've mentioned Better Health Partnership is a collaborative between a number of healthcare systems within Northeast Ohio, not all of them, and they are the drivers of the kind of shared data and shared metrics system. And they've wonderfully brought us in as they work on the clinical side, how the clinical partners can share data, and now they're trying to work with us on what does it mean to bridge community and clinical.
So do you have, with those, the things that you measure, like life expectancy and things like that, so you're saying that your KPIs for sort of community connectedness were the results of questions like that? Do you feel safe and welcome? And so you can look at that changing, and you're taking those samples from these activities, the movies, the runs, where do you get?
Yeah, I'd say there's multiple levels. 'Cause
Yeah.
there's kind of every number of years, we haven't decided what it's going to be. There's like the big longitudinal study.
So
and
with
then
the,
there's kind of short-term pieces that we can learn from.
so those activities, though, you mentioned the movies, the farmer's market, the cooking, the runs, the bike rides. Where did the process of saying, oh, you employ things like that instead of, say, workshops or education, you know, things that look like a little more directly aimed at targeting a certain ailment, these things that you know are gonna, the byproduct is gonna be connectivity, and then that is gonna help address some of the social determinants. Who started coming up with those ideas, and where did they kind of come from? And then also, what are the ones that you didn't mention that you tried?
I think our committee is incredibly robust and helpful in that sense, because our committee has such a diverse series of perspectives. We will come and say, all right, let's have some brainstorming. Let's workshop this. And because the committee is residents and researchers and public health professionals and community development people and affordable housing experts, we can't approach it in kind of a traditional way, because that group would create this weird Frankenstein.
Yeah, and part of that is a lot of it, like specifically like coming up with what programs were offered. That's something that we got from the residents. You know, they were like, "Oh, we don't have a yoga studio in the neighborhood. I have to like go somewhere else to do that. Like, wouldn't it be great if we had something?" So like that's the easy answer for that specifically. But as far as like the term that you kind of hit on was, you know, why programmatic or like programs rather than like workshops and like health education. Things specifically like having people come to a room like this and talk about it.
Yeah.
How many people like really show up to that? Like, is that really what people are gonna want to spend their afternoon or evening doing when they have childcare to worry about? How are they gonna get their groceries? They have to make their dinner, you know, we have to get kids to the sports events. So it just wasn't something that was working for us specifically. We had some of those meetings. They didn't, you know, we had like 5-6 people, which is great for those 5 or 6 people. But in those conversations that we were hearing from our residents when we went out into the community and talked with people where they were comfortable at a coffee shop, in the library, at Esterbrook Recreation Center, you know, that's when we learned about the pieces of their health that were important to them. So is it those fitness activities? Is it the cooking demonstrations? Because like we heard, we're like, oh, we don't really know what to make with this eggplant. And so it's like, you know, that was how those programs kind of came about. We heard people talking about wanting to start a walking group. So we helped residents start the walking group at the market. And so I think that was the really important piece of that, is that if you label it as like a health education workshop, like that's not fun. So, you know, what is it that people are interested in and want to attend? And that's kind of how we looped that piece in.
So you're looking at those as you're placing a workshop with a party of some kind. I mean, in a sense,
I would
it's something
say
enjoyable.
It's meeting residents where they are, both physically but also interest-wise.
Yeah.
And knowing that we can drive an intervention towards an outcome, towards a
Yeah.
KPI, but doing it in a way that they are going to own and love and do every week.
Yeah.
Instead of saying, hey, come to this class.
Jeff, do you remember the first public meeting we had for the skate park in the Flats?
What?
That public meeting?
Was it the one at Great Lakes?
That was the one before that. It was at Speakeasy. And we didn't call it a public meeting. We had a, I don't even know what we called it, but we had a public meeting, so no one came to them. And we had them in the convention center. People had to figure out a park, and 14-year-olds are like showing up with their skateboards, and guys looking like, no, you're not coming in here. And then we learned, and I don't even know what we called it, but we had it downstairs in the Speakeasy, and you guys were there, and Simpron was there, and Silliman was there. And you know, we had 150 people. They couldn't even sit, but it was like, we ran a public meeting. I mean, it wasn't any different, but we didn't use that banner, and that launched that project with so much momentum.
Just to play off of that, we moved most of our community listening sessions to where things like that, and so as a great example, coming up in a couple Saturdays, we have the kind of a Main Street small business Halloween thing. We call it Folloween. There's a play on the word. We sit and engage with the families as they're trick-or-treating up and down Main Street, asking about their health barriers, about their life, about what they want to see in the park next door to that space while they're there, instead of asking them to come back to a silly community meeting. We just move our meeting to them.
I'm curious, what's one thing you've learned through this process that you wish you knew when you started?
You want to go first or me?
No, you go ahead.
I had no idea how massive the clinical community gap is until we got into this. So we've now, because we're a leader in this space regionally and nationally, we participate in a lot of conferences, and everyone I'm at is just, first of all, let's start that gap is budget. So Metro Health is a very close partner of ours. Metro Health's budget is 1,000 times my budget. Like, the scale of what they do is just on a totally, their technology is different. Their language is different. their expectations in terms of response and how they respond and where's that response go is totally different. Their awareness of what happens, I'm not calling on them but they're a close partner, so we can have these frank conversations, is totally different. And it's not out of ill intent. It's those systems that just kind of build up over time. Working on this Healthy Housing Collaborative, and we had someone from Metro Health present who said, so we know that there's all this data out there that if we improve housing outcomes out in the neighborhood, our patients will be healthier, and that's good for us. And they were sitting in my damn conference room, apologize for the language, and they said, are there any housing groups out in the neighborhood? I'm sitting right here. Like, there's just a complete lack of awareness, and vice versa. I've learned so much regarding clinical care and data processes and what they're tracking and how they're paid, which is helping us get better at data integrity, helping us get better at measurement, helping us get better at but that gap is massive.
So what's helped you navigate that gap a little easier?
It's the common table. It's the common table, and that's taken time. It doesn't happen in 3 months. It happens over 9, 12, 18 months of meeting consistently, learning to trust the Health Metrics Advisory Committee that we're part of through Better Health Partnership and Metro Health. We're 12 months in, and we had our what are our big learnings? And our learnings was that there's data on the other side that both of us can benefit from. It took us 12 minutes just to understand that.
Do you feel like that gap is going to get smaller, though? Because, I mean,
Yeah.
your work is going to help their outcomes.
And
so once they realize that, I mean.
It needs to, and both sides needs it. I mean, at the symposium yesterday, both sides know we need to get there.
Yeah.
It's really hard. Because there's the legal challenges with HIPAA.
Right.
There are the obvious just technology challenges. I mean, we use a lot of paper surveys and Microsoft Excel. I won't be ashamed to admit that.
Yeah.
They don't.
Well, you're out in person on the corner.
Yeah.
at
Well, and they want our data. I
Yeah,
mean,
we went there, we can't do it that way, but we would love to have it. I mean, after those events, the feedback, the questions, even the following thing, you're not following them with an iPad necessarily, are you? You just have a sheet and.
No, we don't have budget. We don't have the budget for
Yeah,
that.
yeah.
It'd be nice. Some Wi-Fi hotspots. Oh, boy.
Can you talk just a bit about how you've, like, all the new initiatives that you were talking about this summer that you did? Like, how did you coordinate with the ongoing activities that are already in place in Old Brooklyn? Because, like, in Lakewood, there's so many things in place that make it a great place, but
Yeah.
yet we still feel that, more can be done. So and we've talked a lot about it in our group, how to leverage what's currently, we call them our assets, right? Our huge asset list. So how have you kept in touch with those assets in Old Brooklyn, or sort of optimize them, or can you talk about that?
On a high level, before Amber, who actually executed everything, could tell you, on a high level, I think that's why rooting population health in community development and community-based organizations makes sense. It's because it's my job to know all of those people and talk with them on a constant basis. That is the definition of a CDC. I mean, that's why we knew that the senior center has vans that sit there idle, that they raise a boatload of money trying to pay for every year. They can't keep drivers because the drivers want more hours. And it's our very job to know all these things that are happening. So there's some built-in benefit of being a CDC.
And then as far as like the different programs, like at the farmer's market and things like that, a lot of that coordination was done by me. And so can you not hear me? And so I was actually the one who every week sent out my emails to all of our programs confirming their attendance and making sure they knew all the things that they would need to know. But I know your point is more about like other things going on in the community. And that does have an impact on attendance at other events. And that's just something, if you're going to do this work, it takes a long time, and to build those networks with the residents who live there, they will come. It just might not be as quickly as you want. And that actually kind of goes along with the thing that I learned the most, because we didn't get to me, but
Sorry,
no, it's
I'm
okay.
sorry.
It came back around, so it's okay. But the thing that I've really learned is that it takes a long time. It's not going to be immediate. And sometimes when you're in the trenches, like I was a couple weeks ago with the farmer's market, I was just like, you know, not no one, but like 3 people came to the fitness activity. Like, that really sucks. But like, what can we do differently the next time? Like, these are all learning things. And so that was more of okay, we did this, this, and this. What if we included a little bit more outreach around this or targeted something in a different way? So I think that's one of the key things is things will take a long time. It is not something that happens quickly. There will be mistakes made. But overall, once you kind of feel like you're getting the hang of it, it all comes together. And like I said, like with the farmer's market, like a few weeks ago, I was just like, oh my goodness, like you're in the trenches, you can't see like the positives, but then you go out and tell people, like all of you, like what we're doing, and it's you see it from another side again, and you're just like, oh, this was really amazing. So I think that's something that to keep in mind as well. It just takes a long time.
Besides the groups and individuals that you mentioned so far, is there any other kind of buy-in that you felt you needed to make this successful?
Just from an administrative perspective, Cleveland City Council, Cleveland Public Health Department, our hospital, and my board, because they all are very important to our organization in a number of different ways. I don't know if you want to go from the community side.
For me, on the ground, more or less, the residents were number one, like always. So if they were not asked, or if it's not something they wanted, they would not come. And so I think that's really important in all the work that we're doing. It's all rooted in our community and the people who live there. It's the old Brooklyn residents that are most important in the work that we're doing. This is benefit for them. I mean, that was our number one question with the farmers market. Who are we trying to serve with our market? So.
Back to the big picture question, though, there are still some funding partners who don't get it, who I will be presenting and going on in this work, and they say, okay, that's great, but tell me about the most recent building you redid. And I'm just like, oh boy. So it's not ongoing conversation.
What about the council? Does she give you, is there any funding? Does she direct funds?
We don't get any council support directly for community health work. As a CDC in Cleveland, we do get some community development block grant dollars.
Yeah.
But not for anything for our community health work.
But-
Both of our council members are very supportive of this. It helps the main council person for Old Brooklyn, Council President Kevin Kelly, started his career as a social worker.
Oh, yeah.
So this stuff is right up his alley.
Oh, yeah, I forgot Kevin was in there.
Can I ask a question about, I know you've done the farmer's market and those activities around it. How do you plan on approaching the harder, big things like housing and green space equity? Those are not
So
soft, such soft.
One of the things that we didn't get to is also within our strategy, knowing when we are the lead and when we have to bring in partners.
Right.
Housing is one in which we have to do so. Green space and park planning is one in which we have to do so. So to get to the green space issues, we are partnering, we have partnered, are partnering ongoing with the Western Reserve Land Conservancy and the Cleveland Metro Parks on the acquisition, remediation, and development of a 26-acre park.
Okay.
So Old Brooklyn CDC is never doing that on our own.
No.
But the
Right.
three of us together, we brought some money, a lot of community support in the planning. Western Reserve Land Conservancy brought support, Metro Parks on the execution and the management side. And just down the road from that, another park planning project with Metro Health, the Affordable Housing Agency in the neighborhood, the Senior Center, City of Cleveland. Collaboration, that's all it is.
But you're trying to drive.
We try and set the table. We set the
Okay.
table, bring everyone and say why this is important to our community's health, and why this is important to their populations. And
So you're owning the starting, okay.
And to go on with that, as far as setting the table is, when we bring in that information and bring those people together, we have data to support it from our CHNA and talking to our residents. one of my interns from CASE is in the process of, she completed focus groups throughout the neighborhood, specifically around green spaces, what residents are looking for, what they would like, what are their perceptions, and having this really detailed neighborhood data to then go to our partners and make the case for why this is important, is really one of the big things that we're able to do.
Since you were using a lot of volunteers for the CHNA, how did you go about getting them? Like, how were they identified?
Volunteers or how we got the surveys?
Volunteers, because you said a lot of it was done by volunteers, right?
So it was done through our academic partners. So it was through BW and CWRU that we went to them and said, can you find us a cohort of students who need hours for their practicum or their, what are the things? Capstone.
Yeah, so with that, because I deal with more of the interns, so the best way to go about it is with academic partners, for sure, just because there are students who need experiences, and especially we have, 3 different schools of public health. We have Baldwin-Wallace, CSU has the consortium, and Case Western has a school of public health, and so there are always students who are looking to gain experience, especially in something such as a CHNA, and that's how I actually got involved with Old Brooklyn, was because I was interested in the process of doing that.
2 years later, we haven't let her leave.
Yeah. And so, it's things like that where if you ask whoever the resource is at the universities and schools, there are students willing to come out and gain exposure to public health practices, social workers, kids who are in the School of Social Work. It would be a really great experience for them, and so it works both ways.
Okay. Does anyone have any last questions? I think it's almost 5:30.
For the record, it wouldn't happen without great corporate partners like MCPC too,
Yeah.
who just opened up a facility in Old Brooklyn within the last 6 months.
Good shout out. Anybody else?
I just want to thank you, Jeff, and
yes.
you
Yeah,
guys
thank
coming.
you for
This has
coming.
been we've been at this process for a long time and looking for concrete examples and a lot of some of ideas that we've floated and looking. I wonder if anyone's tried that, and it's awesome, 7 miles away, right, Trish?
Yes,
Yeah.
and I think it's
This is
interesting, it's the
so
only,
awesome.
I think you're the only CDC in the city that has health as a focus. I'm sure, my neighborhood certainly
We're
doesn't.
one of only 3 or 4 in the country.
It's just amazing,
Wow.
it's just amazing.
Yeah.
and it's
Anytime
right
y'all
up the
need any
street.
help, count us in.
Yeah. Thank you so
Thank
much,
you
guys.
very much.